All right, everyone, we are live on Hernia Talk. It's another Tuesday with Dr. Tofi. As many of you know, I am a general surgeon who really enjoys the evaluation and treatment of hernias and hernia-related complications. You can follow me at HerniaTalk on Twitter and Instagram. This is also live on Facebook currently, and you can follow me on my YouTube channel where I will post this at the end of the session. Today we have our amazing, how do I explain this? I feel like he's my partner on the other side of the United States in New York, Dr. Mark Zoland. He works at Core Surgical in New York. You can follow him on Facebook at GLSNY LLP, which I believe used to stand for General Laparoscopic Surgery of New York LLP. And without further ado, welcome Dr. Zoland.
Great to be here and honored to be here.
You know, for those of you who don't know, we kind of talk a little bit beforehand. This is the first time I've actually met Dr. Zoland, but we have shared scores of patients, mostly because they go to East Coast and West Coast looking for specialists, and they see other doctors, but I've shared a lot of patients with Dr. Zoland, and I know him. He stood out for me because of most of the surgeons that these patients go to visit. I agree with Dr. Zoland's assessment more than any of the other doctors they see. I feel like everything that I would say and interpret, like you would say, or you have said when they've seen you. So it's really an honor and pleasure to finally meet you, even though it's virtual. And I can't believe that we're both in the same field and we've never physically met before after all these years. I'm not young. I've been around for a while, so I don't know why we haven't met before.
Yeah, no, we definitely overlap on quite a bit.
Yes. So Dr. Zoland's practice is in New York. Are you in New York City, actually New York City?
Yeah, I'm on the Upper East Side of New York City on 58th Street.
That's a nice place.
Yeah.
I mean, Beverly Hills is nice
been
too.
there
Like
for a
I said, I
long
feel like
time.
we're like twins in many ways. So Dr. Zoland, you're a board certified general surgeon, is that correct? You're a general
That's
surgeon by
correct.
training,
Yeah.
just like me. And then just briefly, how did you get involved in this niche? Or do you also do other general surgical procedures as part of your practice?
Right. So, I mean, I was a bread and butter general surgeon for a long time. And I just found that the groin anatomy was wildly complicated and very poorly taught. And ultimately, I was tasked to teach the residents the groin anatomy, and we started working with cadavers and understanding it. And we started using MRI technology to really take a better look at it, because I think from the radiology point of view and from the general surgical point of view, it was just a very difficult area, very probably the best way to describe it is just a poorly understood area. I don't think we have a perfect understanding even now, but I do think we're getting much, much better at it. And it just became a little bit of a passion, perhaps an obsession. And then I went into specifically groin pain, sports hernias, occult hernias, pelvic floor pain, because it just seemed like there was a need for it along with my obsession, so they went hand in hand.
I think it takes a special person to get into this field because it is complicated, but at the same time underappreciated. I mean, when you were a resident, did you want to be a hernia specialist?
No, I wanted to do the
No,
big
right?
cases, right? The big cases. But
Yeah.
yeah, no, it destroys people's lives. It makes people miserable.
Yeah.
And it's just not very well received or understood. So it clearly was something that needed to be addressed, and I think you know it's just certainly been fulfilling for me. It's hard. It's hard. I mean, I think you get a lot of success sometimes, but you also get failure, and for big-headed general surgeons that we all are, people don't like failure, and you have to be you have to keep going, and I definitely think that that's a part of why so few people really delve into this so deeply.
Yeah, we had a couple of sessions in the past on HerniaTalk where we talked about the need for specialists in this field
Hmm.
because there's so many that have recurrences or chronic pain or uh, undiagnosed groin pain that are kind of lost in the kind of general surgery world.
Right.
And pain doctors don't really understand what we do, and the gynecologists don't really know much about groin pain outside of the ovaries and the uterus, um, and some endometriosis. And so we overlap with urology and gynecology and orthopedic surgery, pain meds, uh, pain management, physical therapy. We overlap with so many specialties, but in residency, the typical residency does not expose you to any of that. At the best,
Right.
you'll get to know how to do a mesh-based open or laparoscopic repair.
Hmm.
I mean, talking for myself, I for sure did not want to be a hernia specialist. That was, I think, in my first job was at USC, and they took me out to like a lunch, and they said, if you were to do one case for the rest of your life, what would that be? And I said, oh, I would do the Whipple. That's like the the god of all operations, right? And I was really good at it. I think I still hold the record at UCLA for the most number of Whipples done by a graduating resident. So that was really cool. And they said, yeah, you're not going to be doing any of that. How about gallbladders and hernias? Do you think that's something you would want to do for the rest of your
Right.
life?
Right. Right.
So I learned to love it. But yeah, I think we're missing. Do you think we need more hernia specialists? Should that be something that should be? I mean, I'm sure your residents, and I know my residents enjoy it, but they still don't go into it. My fellows do. Almost every
Yeah.
fellow we've had in the past several years has come to our program because they want to do abdominal wall hernia,
Hmm.
chronic pain. They've gone back to major institutions, academic institutions, to start their own hernia center. So that's been good.
Hmm.
But I don't know. I
Yeah.
feel like there's aren't enough of us to teach.
I think that it's a little bit of a catch-22. Very few practices would want somebody so specialized in this area alone because they
Hmm.
need the general surgeons to cover the call and to cover the emergencies. So um, I don't think necessarily that we need to produce more people that are so highly specialized. I do think we need to train them better. I do think we
Yeah.
need to have a broader and better understanding of what the problems are so that the residents can start from the beginning understanding that this is more than just a first year level case, and that the diagnostic component of this, which is eminently far more important than the actual surgical component. I mean, yes, we have to be good surgeons. There's no question about that. But most of the surgeons that are being trained are good surgeons. So it's really more about judgment. It's about how you make the diagnosis. It's about thinking about the algorithms. And for me, most importantly, it's the relationship with people that are really interested in these difficult problems. I think, pelvic floor physical therapists to me are dear to my heart because they go deep with this. I think the pelvic floor physiatrists, I think my overlap with groin pain goes deep with the hip surgeons. So
Yes.
as long as you have this group of people around you that um, go as deep as you try to do, and then you need your specialists in terms of radiologists who care about this, who are not just looking to get through the read and spend as little time doing it and get to the next one and the next one and the next one, and they're not really looking for the subtle abnormalities. You need to find those people that really care about getting it right. And quite frankly, I'm sure you do this too. You train them. You train them like you were trained, and you really work on finding yourself a group of people around you who see it the way you do.
Yeah, I totally agree. We were talking earlier, and uh, I 100% agree with your impression that even though we're surgeons and everyone thinks all we do is operate, the history is absolutely what triggers like my algorithm for what diagnosis I'm going to go after and what the treatment protocol is. And I feel that a lot of what we do, if the patient had an obvious hernia, for example, on exam, then your average general surgeon would diagnose that and treat it. We don't get that. But what we do get is a story that then will lead us towards either hernia or hip labral tear or pelvic floor dysfunction or endometriosis or something uh, that explains the patient's um, groin pain. How much of your practice is related to that, like groin or hernia related?
It's my whole practice. This is all that I do
100%.
now.
Yeah, me
Yeah.
too.
So
Me
it's
too.
become busy enough, and certainly the need for somebody who really goes deep in this is out there. And I do feel bad many times that I get calls from people in different states, and they ask me, do I know somebody that would be able to take care of this, like we do? And oftentimes I don't have a name for them, and they end up flying out to you, or they fly into me,
Yeah.
which stings, because there should be somebody that does do this. And quite frankly, that doesn't mean that there isn't somebody. What I'll often counsel patients to do in different states is really do their homework with the surgeons that are around them. And what I'll even do sometimes is I'll try to vet those surgeons for them to see which ones seem like they would be the type of surgeon that would go deep on the things that we're talking about.
Yeah, I
um,
totally agree.
but unfortunately, a lot of people do end up having to travel to come and see us, and I love to take care of these patients. I think it's an honor and a privilege, but it would be nice to keep them at home, to get them to see the people
What do
that I
you
work with.
offer the out-of-state patients? How does your office handle those?
So oftentimes they'll call and they'll ask if there's anybody near them, and if we don't have somebody, we have them send the images. If we can take a look for them, I wonder if you do that. Do you take a look at
Yeah,
images for people? Yeah,
a
I mean,
lot.
a lot, yeah, and I think that that's the best that we can do. I mean, I think that um, if people, so my feeling and what I tell patients is, if you think you have something going on, and this is really important, and you've seen many doctors who tell you that you don't, keep going to a different doctor. The simple fact is, a lot of doctors don't know the answers, and we don't know the answers. We don't always know
Sure,
the answers, and most
sure.
certainly we're not always right, and most certainly we may find hernias that are not the source of your pain. So at the end of the day, we're all just trying to find the truth. Nobody's doing anything on purpose wrong. But if you almost feel like that you have something wrong in your body, and you keep running into that wall, search outside the circle. Expand the circle as you need
Yeah.
to. And the internet has been fantastic for that. And I think that has also let us expand our ability to train people who are outside of our circles, to look for these things a lot more than they had in the past.
Yeah, I offer what's called an online consultation. So they basically it's purely by email and mail. So the
Mhm.
patients send me all of their history, op
Right,
reports, whatever they need. A
right.
we have a questionnaire they fill out, and they send me every single CD of their images,
Mm-hmm.
and I review that and I write up something for them, and they're free to take that right up to their local doctor to see if they're willing to get that care that I recommend closer to home, or they may choose to come see me afterwards because they haven't been able to get anyone else to take over their care. But that's been really helpful because there's so many people that they're willing to travel if they know they're going to get help, but then it would suck if they come to me and I'd be like, oh no, you have a hip problem.
Right,
They
right.
can do that. They should be able to do some of that
Yeah,
um, kind of virtually. And now with COVID, virtual consultations have really upticked. So
yeah,
that's been I think very helpful too for people out of state.
yeah. And to that point, I really think that getting the imaging, looking at the imaging, before dragging the patient out to see me is important, because, like you said, it would suck to have somebody come all the way out just to find out that either they don't have a hernia
I would
or,
feel bad.
yeah,
Yeah.
absolutely.
Yeah.
So I think you and I are very much on the same page that way.
So you bring up imaging, as you know, that's my thing. I love reviewing imaging. I find it like a puzzle solving. I really enjoy the process.
Yeah.
I'm like an artist at heart, so I kind of like that 3D visual as well. And I've learned a lot. I believe you're the same. You've the patients that we've shared, I've noticed you have interpreted imaging similar to how I had interpreted it. You
Mhm.
kind of validate me in some ways.
Right.
But you've also noticed how, unfortunately, the majority of imaging done for this subset of patients, small inguinal hernias, etc., are misread. I think our study was something like 3 out of 4 are misread.
Mhm.
They either say there's no hernia when there is one, or they don't even mention whether there is or they just never looked for it.
Right.
Um, yeah, so that's like your pet peeve too, I think.
Yeah, no question. And I think, again, it's not because anybody's trying to do anything on purpose, or any particular radiologist is bad versus good. You know, it's about their training. It's about the definition. And in one of my lectures for the endometriosis summit, one of the big points was that um, the definition of a hernia for a radiologist might actually be different than the definition of a hernia for us.
Yes.
Um, Radiologists are often trained that if you don't see bowel, or you don't see a huge bit of fat going into the opening, that they're not going to call a hernia. And yet,
Or
as
peritoneum,
I'm sure
yeah,
you've talked about this before, a small piece of fat going into the opening can actually cause more pain than a large one. So if they're
exactly.
not going to call fat going into these openings, and the openings that we see most commonly, of course, are the inguinal, femoral, and obturator canal openings, um, you're not going to get hernia diagnoses when indeed these are hernias. And what I try to explain to the radiologist is, it's not what is going into the opening, it's that the opening exists in and of itself. Because it doesn't matter what goes into the opening, anything going into the opening can impinge upon the nerves and can cause
Yes,
pain. So at the end of
yes.
the day, it becomes a definitional problem. And I'm sure you on your end and me on my own end are trying to change the definition. It's hard. It's swimming against the tide. And
Yes.
even earlier today, I was speaking to somebody who's a terrific radiologist, but he was, really having trouble agreeing with me that it was an actual hernia. So I said, listen, don't say hernia, but say that something is abnormal. If
Yeah,
you
just
don't
explain
mention
it.
the
Explain what you see
abnormality,
it.
right, exactly. Explain what you see, because if you don't mention it, then people walk around with a piece of paper saying no hernia seen, and every single doctor after that who does not look at the imaging is going to say, well, you don't have a hernia, obviously, move on to the next possibility, when that was the possibility that was missed.
So I had a recent one too, a couple weeks ago, where I operated on a patient, a very rare internal hernia. It's not an abdominal wall hernia, but I like to solve mysteries. So sometimes they come to me with like, why do you think I have this pain? Um, and the imaging was pretty classic for exactly this paraduodenal hernia.
Mm-hmm.
And I operated on the patient. He's cured, but for 5 years, young guy, 5 years, he had this unrelenting pain, starting to lose weight, etc. And I emailed the radiologist. I found their email. I emailed them and said, "Oh, just by the way, back in 2000 and something or other, when you read this email, I just want to let you know I operate on him, and the imaging is definitely consistent with that." And my hope is always like, "Thank you so much. Oh, I really appreciate it. You're absolutely right." Or, "Yeah, in retrospect, you're right." Something.
Right.
But more often it's like, "Oh, well, it's based on your
Hostility.
interpretation," or "these are hard to identify," and it's a little bit defensive.
Yeah.
And same with doctors. Like, I've always thought that if I operate on let's say a recurrence or a meschoma or something, and I saw something clearly wrong, I should reach out to the doctor. I did that early in my career, and I didn't have a single doctor that said thank you. It
Right.
was mostly like pissy, and I was a bad person, and I was questioning something they did wrong.
Right.
And so I stopped doing it, but I feel guilty that I'm not giving feedback to people to change their
Yeah.
treatment. Do you feel
Yeah.
that way?
I
I feel really bad about it, but
I do.
I keep getting
I
hit back.
Yeah. I just keep going forward with it. I try not to take it personally. I try not to make it personal. Um, I think for me, it's just about the accuracy and the truth of it. And if they get it wrong, I'd like them to know that they got it wrong. So hopefully they're going to be the 1 out of 3 that actually takes it to heart and says, "Oh, I understand what you're saying."
Right.
Um, but that's the best we can do. I mean, I think, and it promotes a lot of anger with the patients if something was missed. But again, the patients also have to understand that it's a definitional problem. It's not any one personal radiologist. So going back to the point of your papers, I mean, that's the start, right? Getting the papers
Yeah.
out there, getting the information out there, learning as much about this as possible. It's the most that we can do, and training the residents. I think that's a big deal. I think we both try to do that, and it just has to widen the circle.
Yeah, I agree. Okay, let's get to some questions.
Okay.
We'll start with a fun one. I don't know if you're an NBA fan, but what happened to LeBron James? Do we know with his groin injury?
I don't
Kept him
know.
from so many games and he's still like
Um,
hurting.
yeah, I don't know, and if I did know, I probably wouldn't be saying here, but I do not know the answer to that one particular question.
I mean, he's part of my city. I just want him to come over and at least get ruled out for an occult hernia because that's treatable. Growing a true sports hernia or athletic pubalgia is very difficult to heal from, but a hernia you can just fix.
Yeah. Well,
Yeah.
the sports hernia can be fixed too. You know, the issue with the sports hernia is that it's. I mean, first of all, it's a misnomer. It's a bad name, but
Yes.
it 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 has under its heading several different injury patterns that we see, and um, unfortunately, sometimes, and this goes along with growing pain in general, sometimes what we see as the injury pattern isn't the reason why the patient is having pain or the player is having pain. And then the other part of this is that the depth of the injury sometimes is misunderstood by the
Mm,
surgeon. And I'm not above this. It's happened to all of us that we might think it's what we call an inguinal floor disruption or Gilmore's groin, but it ends up being more of an athletic pubalgia problem where you have an attachment to the pubis issue, or
yeah.
it even goes deeper than that, that entire plate can be up and off the bone, and you can actually have a fibrocartilage disruption of the adductor. So at the end of the day, what ends up being really important with the player is, the history, the mechanism of injury, and the right type of MRI, because this really, really helps at least me distinguish one injury from the other. And I think therein lies sometimes why you have some of the players healing and some of them not as well,
Mm,
because if you treat each of them as the same carbon copy problem, you don't always end up with as good a result as you should. And I don't want this to sound like I know more than all the other people. I do not. I just think we all need to be very careful when it comes to these aponeurotic plate, sports hernia, athletic pubalgia injuries. Um, the imaging is critical. I do a lot of diagnostic testing. But going back to the question, bringing it home, I do not know what happened to LeBron James.
all right, maybe we'll find out soon.
Yeah.
Okay, so based on that, can you just briefly go through your treatment algorithm? Because most of it, correct me if I'm wrong, most of it is non-surgical. The typical
Uh,
patient with a sports hernia, athletic pubalgia, aponeurotic plate disruption, um, and the first line of treatment is non-surgical, correct?
it depends on the timing.
Got
When
it.
we did a paper in 2014, we looked at 119 patients with the aponeurotic plate athletic pubalgia injury proven on MRI. And what we found was that there were two uh, everything was based upon time frame. So if you get the injury within the first 6 months and it's an acute injury, there is a greater than 50% chance, or about a 50% chance, that they are going to heal on their own. So if it's within 6 months of the injury, we almost always have people rest. And the reason being that, why do a surgery when half of those people are going to get better on their own anyway?
Right.
Certainly nobody needs a surgery that they don't need. However, we found that when the injury became more of a chronic injury, and we use 6 months as an arbitrary line, but that seemed about right to us. If it's somebody that's had pain going beyond 6 months, they hit what I call the plateau, meaning they essentially get better to about 70%, 80%, and then they essentially live on that 70% plateau. And every time they go out and play the sport that irritates it, it hurts. And then they rest and it gets better to the point where they're completely better until the next time they irritate it. So when you find a patient like that, they've hit what I call the chronic stage. And those patients do better getting the operation because ultimately they've essentially waited their time frame. But if you see somebody in the initial period of the aponeurotic plate injury, you definitely want to have them rest and shut it down. The problem is, of course, a lot of these people are like all of us. We're all a little obsessive, and they don't shut it down like they should, and they don't give themselves a chance to get better. Some people just don't want to. The professional athlete is a different entity altogether because they have a season coming up, and you have to, and the college athlete and the high-level high school athlete, you
Right.
may want to treat them a little bit differently because they're not people that are going to want to wait 3 months or 6 months to find out if they still need an operation. So at the end of the day, it's more about the timing than it is about all across the board.
And is MRI your go-to, or do you use ultrasound? Always
Always,
MRI. Yeah,
yeah.
I agree.
I mean, there are reports about sonograms, but I'm an MRI guy both for hernias and for athletic pubalgia. I think at the end of the day, it gives me a huge amount of information.
Yeah.
We do what we call a pubalgia protocol, which we wrote, and we've been kind of dispersing it throughout the country, both in papers and sort of individually. And I think that, it really gives us a significant amount of information that we can go on.
So we have 3 questions on MRIs for you. I think we have a budding radiologist in our attendance
Okay,
here.
hit me.
So talking about looking at the MRI images, there's there's like the bright and the gray to try to determine. So on this one's, I'll just ask you the question. You can kind of phrase it however you wish. On T2 fat suppressed images, do gray intermediate signals suggest injury or only bright white high intensity signals? And also, what's the difference in appearance between acute and chronic injury on MRI? Maybe just make it as general as you can say, but definitely you can tell acute versus chronic, and you can also look at the different image modalities with an MRI to determine where inflammation is versus like a tear.
Right. So I mean, this is actually a really, really good question. The bright signal that you see suggests that it's an acute injury.
Yeah.
The intermediate signal suggests that it's more going into the chronic phase or that it was an acute injury at one point. And the way we think it happens, and we don't know for sure, but what we think happens is after the acute injury where fluid is deposited or leaks into the area, as time goes on, the body does dispense of the fluid, and the intermediate signal we believe is the scarring effect. So this goes along very much with when you're talking about T2 fat suppressed imaging,
Right.
when we see somebody and their history, and again, this goes back to our point that history is incredibly important. They have 2 weeks of an injury and you do a scan and you see bright signal, you know that they have the acute injury, and that person only 2 weeks out, we have them sit it out and rest, and hopefully that acute injury will just heal. And certainly there is most definitely a percentage of people that are going to heal on their own without an operation. When you have somebody who's got 8 months of pain and they don't have any acute fluid signal, but they do indeed have intermediate signal that's into the adductor fibrocartilage, underneath the aponeurotic plate, between the plate and the pubic-periosteum, you're going to be thinking about that much more as a chronic injury, and that goes along with the history pattern. So that's a really nice correlation that we see, and that's a very good point that the question is making. What's hard is when it's completely inconsistent, when you have somebody with 2 years of pain, and yet you continue to have an acute injury pattern. Then you kind of wonder, why does this patient keep injuring that spot? And those patients you want to sort of delve into a little bit more. Oftentimes diagnostic injections, you want to question yourself. You always want to question yourself. Am I missing it? Am I getting this right? Am I getting this wrong?
Right.
Does this go along with their story? I mean, all of this is really important.
And do you do your own injections, or do
It
you have
depends.
your pain doctor do it?
It depends. If the patient is easy when it comes to their anatomy, and what I mean by that is if it's, you know, a 25-year-old thin athletic man or woman, you can really feel the anatomy very well, and I'll do it by feel. If I have a patient who's whatever, you know, 55 and has packed on the, you know, the 55-year-old weight gain that we often see, me included, you know, then it's a little bit harder of an injection to do. And oftentimes those I'll give to my interventional radiologist or my pain management person to do a sono-guided injection. There are definitely times where I want to do the injection myself. There's something about the surgeon knowing where the anatomy is and doing the injection by
and getting that
feel,
feedback as to like
getting
how
that
they feel
feedback.
immediately.
Exactly right. So I think that sometimes sort of is a big component of it for me.
Are these steroids? Do you use
No,
PRP?
no.
Is it just local
I'm a
anesthetic?
diagnostic injection kind of guy. I mean, and what I mean by that is I do Marcaine, which is bupivacaine, which gives me a 3-hour window. When it comes to pubalgia, I very rarely want somebody to get a steroid injection. The concern anecdotally is that you can end up making the pain go away, but because you're not repairing the injury, you're setting somebody up for a worse injury. And we've seen this many times with some of the professional athletes where they ultimately tore off the entire plate because they just
they
kept
get like
playing.
100 milligrams or something of steroid. It's crazy.
Yeah, and they try to get
120
through the
milligrams.
playoffs and things like that. You know, or the adductor fibrocartilage becomes disrupted. So I'm very cautious about steroids. PRP, stem cells, I believe that there's a role for it. The truth is we don't have good data one way or the other. So I'm never really too negative about it, but I also don't do it myself just not to muddy the waters at this point. But I don't, you know, I think it's a reasonable attempt to go after something if you have somebody that knows what they're doing. But at the same time, you know, we just don't have data on that.
And then also about injections. Oh, hold on. What did I just do? Excuse me. What about Botox? Do you use Botox in your groin pain patients or your athletic pubalgia
I
patients?
don't, but I definitely have pain management people that I know do. And ultimately they're, you know, some of the stuff is very well received. I think that at the end of the day, for me, where it's been probably the best used is in the pelvic floor dysfunction patients who are just going into pelvic floor spasm.
Yeah, those are really good.
Yeah. But for the pubalgia injuries, I just haven't really seen that Botox as a big part of the equation.
Question about, again, sports hernias. If it's left untreated, have you seen it then on the other side? I mean, is there a risk of bilateral issues, or is it always a unilateral problem, or most likely unilateral problem?
Well, I would say 50% of the time I'm seeing bilateral.
Oh, wow.
Yeah, so I don't think there's any question that we see a fair amount of bilateral injury. Is it because one side is left untreated? The truth is I don't know. It's actually really, I've never even thought of it like that, but it's a good point. So just a point of interest, you know, when I'm looking at this, there's a slightly different pattern that has emerged You can either have a unilateral injury, which is signified by what we call a cleft sign on that one side. You can have a bilateral injury where the cleft sign seems to go right across the center. And then there's something that's a slightly different entity that I've been seeing over the last several years, which to me is a little bit distinct. And it's what I call central pubalgia, which is where the injury is really isolated to the very center. It's not the symphysis itself, it's anterior to the symphysis, but it has a slightly different pain pattern. This might be getting too deep, but it just interestingly, that those are the different patterns that we do see on the MRI that do correlate fairly well with the clinicals.
We have another question from Facebook Live. So in people that have groin pain, whether it's due to hernia or an athletic component or a tear, and it's COVID, you know, people don't want to go to doctors or hospitals or leave their house. What do you recommend for them to do to kind of alleviate some of their symptoms?
Yeah, that I don't feel comfortable giving advice. I mean, I think
ice packs. I like ice packs.
sure, ice packs are never going to hurt, but I do think that it's really pathology dependent, right? I mean, you know, I mean, at the end of the day, if somebody's got an incarcerated hernia, all the ice packs in the world are not going to help them. They need to go to the emergency room. If it's athletic pubalgia, and somebody knows that it's athletic pubalgia, then sure, ice packs, nonsteroidals, that type of thing. But it's really hard to dispense advice until, you know, and often patients come in and say, well, you know, what are we going to do? What's the answer to what we're going to do? And you know, at that point, we're just starting the interview, and you know, part of it is, well, we haven't come to a diagnosis yet, so we can't really tell you what the next step is. Let's just try and get to a diagnosis. So that's, you know, unfortunately, I get that COVID is an issue, but you don't want to have people ignore something that might turn into something bad. So hard to give advice in that setting.
Many questions about the bone, the periosteum. One, I'll give you a couple of the questions and you can answer them together. One is, I have concerns about suturing the muscle to the bone and periosteum. Does that cause pain, or is it at risk for causing pain? And there's a similar question, do bone anchors cause less pain than sutures when placed in the periosteum? Also, is there, again, another question about suturing in the periosteum. What are your thoughts about bone anchors, suturing, chronic pain related to periosteal suturing or bone anchors, and like osteitis pubis, I guess, is probably something they're relating to?
Right. Well, osteitis pubis has its entire own HerniaTalk live. So I don't want to delve off into that. But, you know, when I first started doing the surgery, I was very concerned about periosteal sutures at the pubis. You know, we definitely do use periosteal sutures when we do a Lichtenstein repair, and we put a suture into the pubic tubercle. And in fact, we need to anchor that mesh and that medial point. So I knew that was okay. I didn't know how okay it was to start moving medially towards the pubic symphysis. But, you know, what was always interesting is that general surgeons have always been told, oh, don't do that. And yet orthopedic surgeons are doing that type of maneuver all the time.
Right.
All the time. So there was such a disconnect for me that we as general surgeons are told one thing, and yet orthopedic surgeons never think twice about periosteum. They never think twice about anything in regards to the bone and chronic pain syndromes. They're putting plates, they're putting screws.
Absolutely.
So I think that was one element. And then the other was, you know, I had to develop an operation that I wouldn't burn bridges, and I could always undo, is the way I felt about it when I first started, because it was essentially like starting with a new operation. So I created the periosteal sutures, not created, but I started using that method, knowing that if it really started causing a chronic pain syndrome for somebody, I can always go and take them out. And I'm happy to say that, you know, 15 years later, you know, it's only a handful of times where the suture seems to be causing somebody a pain syndrome. I'm absolutely not saying that it can't cause somebody a pain syndrome, but it really just doesn't seem to happen all that much. As far as the anchors go, same thing. The anchors have been extraordinarily helpful when we deal with the fibrocartilage injury, where the adductor longus fibrocartilage comes off the periosteum, and you can actually anchor it back up to the underside of the pubis. And we've had wildly successful results with that operation. And we don't end up with chronic pain syndromes from the anchors. And that goes along with any of the orthopedic literature that we've seen over the years, that anchors are used extraordinarily regularly with orthopedic surgery. So I think that the general surgeon's fear of this has been a little overblown. I'm not sure why. I'm not sure where it came from. But quite frankly, I haven't seen it as a problem. I think the question that somebody asked is a great one about, do we think anchors may cause less pain or less irritation than sutures? Instinctively, my answer to that would be probably yes, because the sutures are holding down a wider swath of tissue. The reason why I don't regularly use anchors, though, is exactly that reason. I need to get as much of the plate approximated to the bone as I can, because that's our problem. The plate is in some way coming off the bone, and there's where your injury exists. And my feeling about suture anchors or anchors in general was that it's a single point of fixation, which is going to then bunch the aponeurotic plate tissue up rather than having a broader catch of that tissue. So in my mind, there was always kind of this back and forth, which one is a better maneuver? And then the second part is, why drill into the bone if you don't have to, I think is a reasonable issue or a reasonable question to ask. And because I've had such good success with the surgery, and again, it's not a perfect surgery, none of this is, there's not a perfect equation here, and I'm certainly not claiming that, but the results have been very, very good. And I think there have been times where I've done an initial operation, the patient recurred quickly. Maybe it's due to their collagen, maybe it's due to the fact that my sutures weren't broad enough, I don't know, but I have gone back and used anchors to treat those patients, and that did pretty well. So that's kind of a fallback position for me. I don't know if I'm getting too technical here, but that was a very good question that somebody asked.
I get that question a lot, because a lot of the patients that come to see me have been through so much and they've done so much research that they then come up with these really detailed questions, which like my own resident probably would never be able to even think of. But it's really impressive that the patients can ask these questions. For the Lichtenstein hernia repair, which is considered the gold standard for open inguinal hernia repairs, Dr. Parviz Hamid recommended that to reduce the risk of chronic pain, the mesh should be secured to the rectus fascia on top of the bone, not onto the pubic kind of periosteum itself. That was his thought, but you're right. Like, orthopedic doctors sew on periosteum all the time. I wonder if they go deeper into the bone and don't catch just the periosteum alone, if that makes a difference. I don't know enough about the orthopedics too.
All I can tell you is for 15 years I've been doing periosteal sutures, and I just don't see it as a big issue.
One thing that you mentioned with regard to pubalgia, the question that's being posed, which is related to what you said, is the pain for athletic pubalgia because of these micro tears, or is it the instability or the abnormal movement of the preaponeurotic complex itself that causes the pain? Is it the tear, or is it like the misalignment or
Well, I think they go hand in hand. I think the tears allow for micro movement, and I think that instability is what people feel. And the reason why I think it has more to do with the instability than the tears causing the pain is because the pain goes from the pubis upwards along the lateral edge of the rectus most commonly, and it goes down along the adductor. So the fact that the pain goes along the two vector forces on the plate makes me feel like it's about the movement of the plate in this kind of tug of war fashion. But I think you can't have movement of the plate with pain if the plate is secure. So I think the tears and the micro tears all play a part of it. So the
Because of
short
the
answer is we
vectors,
don't, the vectors, yeah. So we don't know
forces,
the
yeah.
answer. But I think it's a combination, and the vector forces are what's not letting it heal.
So
That's
there
my
are
vision of that.
surgeons, there are surgeons that claim if you broaden the muscle attachment to the plate, to the
Right,
bone,
right.
that distributes the tension broader and changes the vectors and is one of
Yes,
the ways of treating this. Do you agree with
yes,
that?
I
Yeah.
do, and I do that. I will bring the conjoint tendon down to the shelving edge of the inguinal ligament to broaden and disperse load. I'm a big fan of logical mechanics to this whole thing.
It's physics.
So right, it's just physics. If you disperse the load, hopefully you're not going to have so much tension on that one spot on the pubis, and therefore you're hopefully going to get a better result. Is it overkill? Maybe, but to me that seemed like the most logical way to do it. Reattach what's broken, disperse the load if it's not too much of an anatomic rearrangement, and also I try to lengthen the adductor a little bit just to get that downward vector pull, which I believe is the dominant tug of war winner, so to speak, just to lengthen that adductor so you're not getting as much of a downward vector pull.
Right. We talked a lot about sports hernias and athletic pubalgia, but we didn't answer a simple question. What's the typical symptom of this process or this problem?
So for somebody with athletic pubalgia, a sports
Yeah.
hernia injury,
Yeah. If that's
sure.
been confirmed, what's the typical symptom?
Yeah, so the typical patient will come in, and when you say to them, "Where do you feel your pain?" they will point to their pubic tubercle. And for those of you that don't know where the pubic tubercle is, if you think of the pubic bone kind of right down at the center, and you just go off to the right, probably about an inch to an inch and a half, depending on the size of your body, there's kind of a step off, a little ridge that you can feel on the bone. And that's where patients almost always point to as the epicenter. I'll always ask them, I understand that the pain radiates, but where is the epicenter of your pain? They will generally
Mm-hmm.
point to that spot. And then when I will ask them, and does it go down? Does it go up? Does it go lateral? Where does it go? They will point in two directions. They'll bring their finger up along the lateral edge of the rectus, and they'll also bring their finger down along the adductor tendon. So that is your typical. Now, sometimes you just have people with an upper plate injury who only feel upper pain.
Yeah.
Sometimes you only have people with adductor pain. But it usually emanates from that pubic tubercle. And the constellation of symptoms is usually activity induced, but interestingly, it's not always at the time of the activity. In fact, I get a lot of people who feel fine when they play, whether it's soccer or hockey or cycling or whatever it is, and then it's later that night, or it is next morning. Next morning,
Mm-hmm.
one of the typical complaints is, I was fine, and then I went to sleep, and then getting up out of the bed was really hard, and then I'm shot for 2 days. And that's a very, very classic sports hernia, athletic pubalgia type description to me. And that goes very much along with the clinicals that we're talking about when you see them in the
Right.
office. And then the MRI often will I think somebody did a great study where they looked at MRIs and they gave it to radiologists who were kind of blinded to what the issue was. And they simply asked, if the issue is in the pelvis, look at the imaging and see which side you see the abnormality and tell us which side you think the injury is going to be on. And it was like a 99% sensitivity that people were choosing the correct side of injury based upon some abnormalities they were seeing at the pubis. And what that told me was that there is a high correlation with what the MRI shows and what the injury pattern is. And in my practice over the last 15 to 20 years, that's definitely been true for me.
Let's talk about laparoscopic surgery. This patient was offered laparoscopic repair with mesh for their sports hernia. How does that end up repairing a muscle injury?
I mean, I don't want to sound grandiose here, but I don't think that it does. I think it doesn't. It never made sense to me. And remember, I'm a laparoscopic surgeon. I mean, I was trained in the time that laparoscopic surgery was really coming up, and for inguinal and femoral and obturator hernias, I adore laparoscopic surgery. I think it's fabulous. I think it's the
Yep.
way to go. There is no other way. However, I've looked at it every which way, and for pubalgia, I just don't see how you're going to get to the front of the pubis laparoscopically in any effective fashion and be able to do all the things that we are doing when we do the pubalgia repair. So I don't do pubalgia repairs laparoscopically, and I don't like to use mesh in these high performance athletes. You know, in that level, because I think that level is where there's, you know, musculature that I really don't want to create such a huge scar tissue reaction with the mesh. And I'm also not really accomplishing anything with the mesh if it's at the aponeurotic plate where the injury is. So I know it's a broad answer and a long answer, but simply I don't think one can get to a good repair of a pubalgia case with a laparoscopic mesh repair.
I think a lot of times people use the term sports hernia because they don't feel a big bulging hernia,
Yep.
which is your typical standard inguinal hernia. And they use it's a misnomer. In fact, I know surgeons that kind of prey on that. They say, oh, we're fixing a sports hernia, and they have this huge kind of camaraderie with the orthopedic surgeons. What they're really doing is they're just doing a laparoscopic hernia repair for a bona fide inguinal hernia. They're just terming it that. It sounds fancier, but that's where we go into the whole occult hernia, hidden hernia, you know, a lot of what I treat a lot of and you treat a lot of. But it's so important to determine the difference. The treatment's totally different. The biology is different. The amount of inflammation and tissue injury is different.
Yeah.
And the recovery is different, right?
Absolutely. And to your point, the MRI to me is again the key to understanding the pathology. And you know, the other thing to note is that in our paper, there was a concomitant, meaning at the same time, hernia incidence as well as pubalgia injury about 30 to 35% of the time. So it's not uncommon that people have a combination, and I think they do go together, because I think people with long-standing hernias who don't really know that they have a hernia and are very active or highly athletic, that hernia sitting there in the inguinal canal causes a different type of torque, which ends up creating more vector force or torque on the pubis. So it remains very logical to me when you think about it mechanically that inguinal hernias quite possibly predispose people, and in the numbers it looks like they do predispose people to athletic pubalgia, you know, in many cases. So I think, you know, there's definitely reports of people repairing quote unquote athletic pubalgia with laparoscopic hernia repair with mesh, but it's quite possible, like you said, that they're fixing these inguinal hernias. It's also possible that they are getting some secondary pain control from the hernia repair with mesh. And I'm not saying that it doesn't maybe stabilize the inguinal floor a little bit, but to me, it's a very indirect way to try and fix what seems to me to be the problem at the front of the pubis.
Yeah, I think that's where the history is really important, because it's a very different history, inguinal hernias usually, than sports type injuries. And then MRI. So one question is, how do you find a hidden hernia if you don't see it on ultrasound? So in our study, ultrasound was great if it was positive, 100% of the time, pretty much. Almost no false positives, but it had a 50% false negative rate. So if you had a negative hernia ultrasound, or ultrasound, it's often not even correctly done, then half the time you are missing a real hernia if it's done for that reason. And then we go straight to MRI. Is that your protocol? We go, if we have ultrasound that's negative, but the history and exam are consistent with our inguinal hernia, then we jump to, I skip CT because it's horrible numbers in terms of pelvic anatomy. So we go straight to MRI for those.
Right. Well, I'm not a big fan of sonogram, because for me that's user dependent and I don't do it myself. So then I'm depending upon somebody else's interpretation of something, which I've learned over the years never to really do. I'll always want the imaging, whether it's a CT scan or the MRI. Personally, I will never get a CT scan if I don't have to, because of the radiation. Even though it's a small amount, I don't want to make it sound like
Adds up.
Nobody
Yeah.
ever should get a CT scan. My feeling is, quite frankly, that for this specifically, hernias, occult hernias, and aponeurotic plate injuries, MRI is going to show you everything you need to see. There's definitely some things that CTs need to be done for, no question whatsoever. However, for this, I'll always go straight to the MRI if I can. Insurances often try and block that pathway, but I
Yeah.
just
I
find
just
that,
give them my paper.
what's that? Yeah, just give them your
I
paper.
just send them my paper and they don't say anything.
I don't know. Nobody listens to me with that. but at the end of the day, oftentimes we'll have to get a sonogram just as a gateway to getting the MRI. But I just find that the MRI is so incredibly helpful.
That's true. We have two questions on recovery from a sports hernia related operation.
Mhm.
One is a patient who relapsed 6 months post-op and was wondering what the causes of relapse are. And a second one is a live question, which is how long do you give post-operative pain to resolve before you would consider removing periosteal sutures?
Um, I mean, I'd like to wait it out as long as I can.
Yeah,
And again, this isn't a high frequency occurrence for me, so I don't really have a set algorithm for it. I think it's going to depend on how much pain the patient is in. Um, I'll almost always do a diagnostic injection for a suture to make sure that it is indeed the source of pain, because I think it's easy to say, oh, it's the suture that's causing pain. You go and you remove the suture and they still have pain, and then you've done
right,
an unnecessary maneuver and taken out something that is securing the plate. That being
right.
said, if you do a diagnostic injection and it certainly is the suture, you can still go with the steroid injection, see if that works. And if that doesn't work, I would like to wait as long as I can before taking the suture out, just because of its structural integrity, helping with
Like a
the
year
repair.
or 6 months, 8 months?
Yeah, so I would say 6 months would be a reasonable
Minimum.
time frame.
Yeah, 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 I agree. Um, okay, let's do one last question. We got some really great questions. Do you treat male and female groin pain differently? How and why? I see a lot
Uh,
of females, so
yeah, I I definitely see a lot of females. I see a lot of overlap with pelvic floor dysfunction. You know, the I don't really think I treat males and females differently. I think I just go for the answer no matter what it is.
hmm,
Will the answers be female dominated in some directions and male dominated in other directions? Sure, the anatomy will dictate that, but I definitely think that um, I walk into a room seeing a patient with the exact same blank slate in my mind for both patients and or for both genders, and I don't think that I look at them mechanically differently so much. I mean, there's definitely differences in the female pelvis when it comes to groin pain and sports hernia type stuff. How I do the repair sometimes is slightly different because I can't fit the same amount of sutures because of my landing zone is smaller, so to speak.
right.
Um, but I don't think there's a whole lot of difference in approaching the patients, because I think you still have to come up with your diagnostic algorithm. You still have to come up with the right answer. You don't dismiss anything in one versus the other. I think you have to track down, like you said earlier, I think we're detectives. We have to track down the leads. We have to try and disprove things that we think are wrong and prove the things that we think are right. And we have to have an open mind. So I think you have to be as open as you can with all of this. I don't know if that answers the question, but
Yeah, I think it does. Of course, there's certain things that women may have that men don't, and vice versa. But I think the important takeaway is that women can get a hernia just like men. Men can have certain disease processes that are more common in women. Uh, to have an open mind and be as kind of broad in your knowledge base and application of that as possible. I have so many people that are told they can't, there's no way they can have a hernia, they're female. I'm like, who taught you that? But they teach that in medical school. I've actually uh, been involved in medical school where they actually teach that, and I have to tell them not to say that again.
Yeah. Yeah.
Okay, sorry, this will be the last question because I think it kind of falls into everything is how do I talk to my surgeon about occult hernias when they don't see them as a real cause of pain? I think we
Well, I
both live
mean,
in that world.
yeah, I think carefully is the word here.
Yeah,
I think you have to make a determination if the surgeon is going to be just closed off or not. If they're closed off, my feeling is just find another surgeon. You don't want to be the one convincing somebody to do a surgery on you that they don't believe in.
that's a
Um,
very good point.
yeah. On
Very
the
good
other
point.
hand, honestly, if you have somebody who's open-minded, you can certainly show them the literature, show them some of the YouTube videos that are out there in the world that, I mean, the two of us have been doing and others, I believe, have been doing in regards to occult hernias. Um, and if it's a surgeon who's a good, solid surgeon, and hopefully they have, a, a good sense of hubris and brains, they'll say, you know what, this is possible. And I think you and I, this is really important in our world. You have to look at every possibility and deem it as a possible issue because we don't know everything. Most assuredly,
Yes,
we
I
don't
say
know
that
everything.
all the time.
Yeah.
Oh, I'm glad you say that. You're basically like mimicking exactly what I say. I say it all the time. We don't know everything. We're still learning.
Hmm.
That will be the same forever. And
Forever.
for some surgeons to claim like they know so much, it drives me nuts.
Yep. Agreed.
All right. Well, on that note, I would like to say thank you. It's our last kind of couple seconds on Hernia Talk. So, Dr. Zoland, thank you so much. You shared so much information. It's been my pleasure and honor to at least be able to like pick you out of a crowd now. I really, really, really respect everything you do. We will have this posted on YouTube pretty soon, and I'll put it on all over social media so you can link to it. Thank you, Dr. Zolan, for sharing your time and effort with me. Thanks,
My
everyone. I'll
pleasure.
see you next Tuesday on Hernia Talk Tuesdays. Thank you very much, and have a great evening. Bye.